Sports injuries are inevitable and unavoidable. Some injuries are very mild, whilst others are much more significant with potential surgical implications. The following are a collection of some of those injuries. We'll look at how they happen, what they look like on ultrasound, and what they mean in real terms. Now, on that list, I have included pec major, biceps, triceps, jersey fingers, mallet fingers, UCL injuries of the thumb and the elbow, Syndesmosis injuries, Lisfranc injuries, Achilles ruptures, and hamstring tendon ruptures. But I'll start with pec major tears, and clinically these are pretty straightforward and easy to diagnose. Here we can see that Tom Dragojevic diagnoses his own pec major rupture within 10 seconds of it happening, and in a state of origin game no less. But on imaging, these are often very difficult, with imaging findings discordant with those found at surgery. And the reasons for this are pretty fascinating. The pec major consists of a sternal component and a clavicular component. As these muscle fibers coalesce to form the tendon, they will twist and invert such that the tendon of the inferior sternal component will be located posteriorly and superiorly, whilst the tendon of the clavicular component will be located anteriorly. Now, on ultrasound, the insertion of pec major is rather underwhelming. We don't appreciate the unique U shape that this tendon has, but it's very important to be aware of, because when pec major tears, it tears predictably from inferior to superior or sternal to clavicular, meaning that the tendon will tear in this type of pattern. And this is why when you have a pec major tear, it looks as if it's just an MTJ tear, and it looks as if the tendon is intact. But if any part of that tendon is intact, that's simply the tendon of the clavicular component, which is often spared. The sternal component, which is located posteriorly, it has torn. It has retracted back into the chest, and this requires surgical management. Don't be fooled by these injuries. These are osteotendinous avulsions that require surgical repair. And the average return to play time for a pec major tear is 12 weeks at the elite level. In a similar way, if we don't understand the anatomy of the distal triceps, we can often overlook or undercall significant tricep tears. This is CM Punk, who in this incident ruptures his right distal tricep. The silver lining to this injury meant The Rock came back to the WWE, but I've seen this in rugby players, I've seen it in ice skating injuries, and you'll see it in guys that are on the juice and who bench press 5 days of the week. Now, we're probably aware that the triceps consists of a long head, a lateral head, and a medial head, but we're probably not all aware on how this tendon inserts. Now, the medial tendon, it inserts anteriorly and deep, whilst the long and lateral tendon inserts posteriorly and superficial. And this is really important to be aware of, because when you have a distal triceps rupture, the medial component will often remain intact, but you'll have a complete tear of the long and lateral component. And if we're unaware of this anatomy, we can often call this a partial tear of the distal triceps, or in some incidences, completely overlook this injury. So in this case, the medial component is intact, but we've got a torn and retracted long and lateral tendon of the triceps. This injury would look identical to this image by Stadnik. Jersey fingers, as the name suggests, are generally caused by footy jerseys. So if you imagine that Payne Haas's left index finger is flexed within the collar of Nathan Cleary's jersey, and as Cleary breaks away, scores a try, wins the grand final, and completes one of the greatest comebacks in the history of sports, the dip joint extends and you can get an avulsion of the flexor digitorum profundus. You have a jersey finger. Now, all jersey fingers are surgical injuries, the timing of which is determined by the Leddy and Packer classification. Essentially, what that asks is how far has that tendon retracted, because the degree of retraction is directly proportional to the damage to the vinculum or the vascular supply of the tendon. So in this case, we have a normal flexor digitorum profundus, and we can see that it retracts to the level of the pip joint, which is consistent with a type 2 Leddy and Packer jersey finger. Mallet fingers, on the other hand, these are generally caused by a ball to the end of the finger. So this is Mitch Starc, who drops a catch He has a ball that hits the tip of his left middle finger. He has a flexion deformity and he's unable to extend the dip joint. He has a mallet finger. Now, a mallet finger is an avulsion of the terminal slip of the extensor tendon. And the easiest way to demonstrate this on ultrasound is to use a horizontal split screen. This helps to improve my diagnostic confidence and also helps to show unequivocally the nature of the injury. In this example, we have a mallet finger with a small bony avulsion. And in this case, we've got a mallet finger with no bony avulsion. Now, generally speaking, these will be treated conservatively in a splint and they will repair quite well. The exception is if there is a large avulsion fracture fragment. By large, we mean greater than 1/3 the size of the articular surface of the distal phalanx, or if there is significant volar displacement. UCL of the thumb injuries is a personal favourite of mine. Generally, these are called skiers' thumbs or gamekeepers' thumbs, but there's not many ski fields here in Australia, and the practice of breaking an animal's neck with your bare hands is certainly frowned upon in this day and age. Now, this is Mike Trout from the LA Angels. So as he slides into second base, he gets his thumb caught on the plate. He has a hyperextension and hyperabduction injury of his thumb. He has an injury to the UCL. Now, what makes a UCL injury a surgical injury is the presence of a stena lesion. Now, a stena lesion occurs when the adductor aponeurosis becomes interposed between the torn and retracted distal end of the UCL and its site of attachment at the base of the proximal phalanx. In other words, the UCL cannot scar down and get back to where it needs to be because the adductor aponeurosis is in the way. So the key to diagnosing a stena lesion is to establish the relationship of the UCL and the adductor aponeurosis. Now, on a normal thumb, the adductor aponeurosis will be superficial to the UCL, and as it is intimately related to the extensor apparatus of the thumb, if we move the IP joint of the thumb, we will see the adductor aponeurosis slide back and forth. And it follows that if any part of that UCL is seen superficial to the adductor aponeurosis, then by definition, we have a stena lesion. If we look at another UCL, this time of the elbow, and generally these are called Tommy John injuries, very common in baseball. Now, Tommy John was a pitcher for the LA Dodgers back in the 70s and 80s. And he blew his arm out, which generally meant the end of your baseball career, but he was the first to have a UCL reconstruction. It's now known widely as a Tommy John injury and Tommy John reconstruction. Now, the UCL of the elbow, it consists of an anterior bundle, a posterior bundle, and a transverse ligament. And the most important component of the UCL is the anterior bundle, which we see beautifully on ultrasound. We can see its insertion of the medial epicondyle all the way down to the sublime tubercle of the ulna. In this case, we've got a partial tear of the anterior UCL in an AFLW athlete who missed no game time for this injury. And here we've got a complete tear of the UCL, or a Tommy John injury, in a javelin athlete. Biceps injuries, which are a sonographer's bread and butter, are generally caused in this type of mechanism here, so that the arm is located down by the patient's side, whereas pec ruptures occur when the arm is in a horizontal position. Bicep tears will occur when the arm is down by the side and the elbow is forced into extension. In the general population, you'll see this in someone trying to catch a fallen weight. Now, we see the biceps beautifully on ultrasound, and there's a number of different techniques we can use to do that. This is using the traditional method and the pronated teres as the window. This is the reverse Leighton Hewitt method, which is perfect for any interventional work. And this is another method in which the probe is placed parallel with the humerus and allows visualization of that distal MTJ. So by using these techniques, we can easily identify partial tears of the distal biceps. We can assess the post-op integrity of a biceps repair, and we can easily diagnose ruptures of the biceps tendon. Now, what the surgeons want to know is whether or not the lacetus fibrosus or the bicipital aponeurosis is intact. This is the lacetus fibrosus here. And we can see that on ultrasound as a small little membrane running from the biceps to insert into the volar aspect of the forearm. Now, direct visualization is sometimes difficult, so the cheap way to do it is to scan the volar aspect of the forearm and look for any cobblestone pebble edema superficial to those flexors. If we see that, that suggests that the lacetus fibrosus is torn, which generally results in a greater degree of retraction of the biceps tendon, and this may change the surgical plan. So in this case, we've got a torn lacetus fibrosus, and we've got a complete tear of that distal biceps tendon. This was in a patient who was doing a deadlift at the gym. If we look at the lower limb now, and the syndesmosis injury is essentially why the hip drop tackle has been banned in the NRL. So this occurs when the defender drops his weight from the ball carrier's hip. The ball carrier's foot, which is planted, will evert and result in an injury to the syndesmosis, create an unstable ankle joint. Now, when we talk of the syndesmosis, we talk of the AITFL, the PITFL, and the interosseous membrane. And we see all of these structures beautifully on ultrasound. Here we have a complete tear of the AITFL, a complete tear of the PITFL, and we have edema throughout the interosseous membrane. Now again, I utilize that horizontal split screen to show normal from abnormal, which improves my diagnostic confidence. And the most important component of the syndesmosis is the AITFL. You can have a torn AITFL and an intact PITFL and a normal interosseous membrane, and this will still result in a surgical tightrope repair. We can assess this dynamically as well. So literally I will grab the patient's calcaneus and twist the calcaneus, and this can show whether that AITFL is intact or whether it is disrupted, such as this case here, and patients will tolerate this maneuver perfectly well. Similarly, Lisfranc injuries have become a bit of a buzzword in the NRL in recent years because it's such a significant injury. The average return to play time for a Lisfranc ligament injury ranges between 10 to 12 weeks, and multiple studies have shown that the athletic performance in the 12 months after a Lisfranc ligament injury is markedly reduced, although Kalen Ponga's performance in the back end of this season may refute those findings. Now, when we talk of a Lisfranc ligament injury, we're talking of an injury to a ligamentous complex that involves an interosseous ligament, a plantar ligament, and the dorsal ligament. Now, the most important part of the Lisfranc is the interosseous component, which we do not see, but we do see the dorsal Lisfranc ligament perfectly well. And generally speaking, if the interosseous component is torn, so too will the dorsal Lisfranc ligament. The easiest way to find this, like any ligament, is to simply line the bones up. So I'll line up the medial cuneiform with the base of the second metatarsal, and we can see beautifully the dorsal Lisfranc ligament. And I include this into every trauma foot and ankle series that I see, because if we can pick up an unsuspected Lisfranc ligament injury, well, that's monumental for the patient and the radiologist. Achilles tendon ruptures, again, clinically a pretty straightforward and easy diagnosis to make. This is Aaron Rodgers, who in the first game of last year's NFL season ruptured his left Achilles. Now, the Achilles is the best named body part there is. This part by which the goddess Thetis grabbed onto little Achilles to dip him in the river Styx and immunize him from death for all of eternity. This part by which Paris shoots a poisoned arrow through the one unprotected part on Achilles' body, killing the greatest warrior that's ever been. And what we need to do as sonographers is determine whether that tear is complete or partial, and we want to determine how far along that tendon the tear has occurred. So I will use the superior tubercle of the calcaneus as my landmark, as this is a reproducible landmark that the surgeon can use. Now, the surgeons that we work with, they want to know the gap between the tendon ends in neutral and in maximum plantar flexion. If that gap can approximate to within 10 millimeters, they will elect for a non-surgical repair of the Achilles tendon. And lastly, hamstring ruptures. Hamstring ruptures are caused when the leg is forced into extension. So you can see that Latrell Mitchell and Andrew McCulloch overstretch their leg, resulting in a hamstring rupture. Now, in the general population, this will generally occur when someone has slipped on the wet bathroom tiles. Now, scanning the hamstring requires a methodical and systematic approach. Now, I will start with the free tendon of semimembranosus and scan proximally all the way to its origin, which is lateral and deep on that ischial tuberosity. I'll then come back down to the distal aspect of the proximal MTJ of the long head of the biceps femoris and scan proximally. We'll see a contribution of fibers from semitendinosus, and we can follow that all the way up to its origin, which will be medial and superficial to the semimembranosus component at the ischial tuberosity. Now, when we have a hamstring tendon rupture, it can be very difficult to identify any semblance of normal anatomy. It'll be replaced with hematoma, blood, and debris. But if we have that methodical and systematic approach, we get used to seeing what normal is, and we can compare it to the other side to help us show that in this instance, we've got a complete tear and retraction of the semimembranosus and conjoint component of the hamstring. Thanks for watching, guys. I hope everyone got something out of this presentation. Like and subscribe for more content. Thank you.